answer that. We'll help Dr. Riaz answer that. Welcome, Dr. Rao, sir.
Oh, good evening.
Good evening, sir.
Good evening,
Good evening,
Dr.
sir.
Rao.
Hello,
Good evening,
sir.
Rao, sir.
Sir,
Good evening.
Well,
Good evening, Dr. Riazuddin.
And good
hello,
evening, sir.
sir. Good evening.
Good
डॉक्टर
evening,
रियाज
Dr.
डॉक्टर रियाज आपका बैंडविड्थ थोड़ा लो आ रहा है, बी केयरफुल। आप एक बार चेक करके
जी
देखें,
सर।
बैंडविड्थ थोड़ा रेड आ रहा है उसमें।
सर
एंड प्लीज कैन यू
आवाज आ
चेक
रही है सर?
आवाज
Start now.
अनशेयर कर
Yes,
दीजिए।
let us start now. All set.
या श्रेया, प्लीज शेयर द स्लाइड्स।
Dr. Riaz, you can stop the slide share. Yes, Shreya can start. Everyone mute. Okay, we are all set now. Go to full screen. Yes, welcome all of you. This is 274th edition of Thursday Musings. Today we'll be talking about ketamine therapy in everyday psychiatric practice, practical implementation from a person who actually uses it, and the chairpersons also use it. So we know today we'll know the ins and out of this therapy. Now the session is being recorded. This will be put on YouTube for later viewing. Questions are invited in the chat box, so you can type the questions, post in the chat box, which will be taken up to the speaker. So thank you from my side. Handing over the next slide, please. Handing over the session to Professor Dr. Tufan Pati, sir. He's the
Thank you,
chairman of this program. Sir, back over to you.
Thank you, Dr. Alim. I have the pleasure to introduce Dr. Alim Siddiqui, Dr. Amrit Patidusi, Dr. Vishal Shabra, and Dr. Shobit Bra, the vibrant moderators of this program. Welcome, everybody. I have the pleasure to introduce our chairpersons, Dr. Challa S.B. Krishnadasan from Kakinada. He studied MBBS at Guntur Medical College, studied MD Psychiatry at Government Hospital for Mental Care, Center of Excellence in Psychiatry, Andhra Medical College, Visakhapatnam, Andhra Pradesh. Experience of years of post-MD Psychiatry. Finished PDCC in Child and Adolescent Psychiatry from JIPMER. Finished PGDMLE from National Law School of India, University, Bengaluru. Areas of interest: mood disorders, forensic psychiatry, child and adolescent psychiatry, addicts and medicine. He got first prize in postgraduate quiz competition held by IPS Andhra Pradesh State Branch. Megastar certificate from NPTEL, IIT Madras for topping 8 out of the 12 courses in a semester. Active in academic activities online and offline. Has got trained up in 51 professional development certificate courses apart from regular academic training. Runs a WhatsApp group called Russian Study Group with an object to help final year postgraduates and passed out young psychiatrists to help each other to pass MD, DNB, crack DM, DF, PDCC, SR entrance examination. Currently with active members who pursue DM, PDF, SR from all major INIs and other young psychiatrists. Welcome, Dr. Krishna. Next, please. Dr. Gaurav Uppal from Ludhiana is our other chairperson. He was awarded University Gold Medal and recognized as Best Outgoing Student, DPM and MD category at Manipal University, a distinction achieved by very few candidates. Successfully completed a Marcy Psych in July 2023 following structured international psychiatry training. Served as Senior Resident of Medical Officer at CMC Ludhiana, managing general audit, adult, child and adolescent geriatrics, emergency and consultation liaison psychiatry services. Chief Academic Coordinator of TIPS, Training Initiative for Psychiatry Postgraduate Program, coordinating nationwide Delhi academic activities, mentoring over 5,000 postgraduate students and postgraduate mentoring. Mentored over 1,500 MRC Psych CASC candidates across multiple international platforms, including KMC Manipal, adjunct faculty, IMSTP, and Study Medic with structured testing and mock examination programs. Published multiple peer-reviewed articles and abstracts in reputed journals, including Academic Psychiatry and BJP Psychiatry Open, with several works archived in PubMed Central. Author of multiple psychiatry textbooks, including Tips Guide, Manual for Postgraduate Psychiatry Basic Science, and other landmark psychiatry manuals widely used by the residents. Abstract and poster titled Slumbers Dual, comparing Durasang with jet drugs, selected for rapid fire round in the Royal College of Psychiatry Congress in 2025. Extensive research in psychedelic assisted therapy clinic and published papers in psychodynamic psychotherapy. Peer-reviewed Springer Nature articles in child and adolescent psychiatry. Currently working in Ludhiana. Welcome, Dr. Uppal. Now the meeting is handed over to you, Dr. Uppal, and Dr. Krishna. One of you will introduce Dr. Riajuddin, who is the speaker today, and both of you will introduce the topic, and then we'll go over to Dr. Riajuddin for deliberation. Over to the chairperson.
Right. Dr. Chada is not there, perhaps. Okay, so I'll just take my pleasure to introduce Dr. Muhammad Riazuddin is Associate Professor and Head of the Department from Aligarh. He's actually the Associate Professor and Head of the Department of Psychiatry, Jawaharlal Nehru Medical College, Aligarh Muslim University, a very prestigious university. He's a Life Fellow of Indian Psychiatric Society. He's a Life Member of American Psychological Association. And he's also a Nodal Officer for Addiction Treatment Facility in Aligarh. The key areas of interest are the movement disorder, child psychiatry, and ketamine-based interventions. He has authored 28 publications in national and international peer-reviewed journals. So welcome, sir.
Can you introduce the topic?
Dr. Krishna, can you unmute yourself?
Okay.
Yeah.
Good evening, all. It's my pleasure to chair this session on the ketamine and practical implications. And I'm thankful to the organizing committee for choosing me as the chairperson. So my journey with ketamine is on the both sides of the table. So I'm a clinician who uses ketamine regularly, and I'm a recipient of ketamine. So both the ends of the table have experience with the ketamine. So ketamine is a glutamate modulator. It is known for its rapid antidepressant and mood elevating properties, which started as a pain reliever, and later it was used for sedation in imaging for children and others, and slowly it came into our psychiatric practice for its rapid onset of antidepressant effects. So ketamine we are using in our center since the past 10 years. So where I am working in Anurag Hospital of Kakinada. So yearly we give around 20 to 30 patients of about ketamine courses. So ketamine is primarily given in IV route and occasionally in oral route. So the side effect we have seen with ketamine is 5 patients who got nausea and vomiting. Only 1 patient in the past 10 years to have cardiac issues, who has a known diabetic and a known cardiac patient. So that monitoring we have to see. So for coming to the effect, for my personal experience with ketamine, so during my depressive episode, I got severe depressive episode post-COVID with severe suicidal ideation. So after my work, I took the ketamine as a oral route initially. So after my first session of ketamine, all my suicidal ideations and the speed of negative automatic thoughts got reduced in the second session. So I got to the baseline. And in the third session, I got start to feel happy. In the fourth session, I completely came to relapse along with the fluoxetine 40 mg. So what are the effects which I have seen with ketamine is immediate and within the first 2 hours actually. So the ketamine, after the ketamine IV infusion, after 1 hour after my IV infusion, happily I went to my house through the from the clinic by riding my bike for 4 kilometers. So it's a very rapid onset of action, and it will be very safe drug as well. So with the ketamine, so I completely got relieved from my suicidal ideation, and I never got it back, and I'm happy with it. So I have the real life experience with ketamine and its safety. And in the clinic also, we regularly prescribe to patients with mood disorders, especially severe unipolar depression. and rarely to bipolar depression, but no significant much significant effect we can see in bipolar depression. And our esteemed speaker from our Aligarh Muslim University, the Institute of National Importance, so he's a HOD. He has a lot of experience in the field, so he will elaborate about the ketamine. And I will hand it over to my course chairperson, to Dr. Gaurav Upal. Sir, please.
So there's nothing much to say after what you just said, Dr. Chala. Yes, it is. It is one of the like miraculous drug actually, and you had the first-hand experience. But even like my experience with the addiction is that what happens is that even addiction is a way how people hide their traumas. So ketamine somehow it uncouples the trauma from the substance use, and then people somehow they suddenly wake up from that kind of state. So that kind of thing also I've seen with ketamine, and absolutely it's a the way, and it's also like the thing is like the ketamine is also perhaps it will come in the discussion. It's also the way it is administered that is also very important, because some of the things now the environment, it's a kind of a like I was also reading this book actually. I'll discuss about this later on. It's by Dr. Geber Mate and Tim Reed and Mera Pepas Perot. So he's done extensive work on the trauma-focused therapy and ketamine and psychedelic-assisted therapy, and also there are a lot of things actually. Like what he describes in this is it's called as a ceremony around, like before starting any kind of treatment. And perhaps like once the discussion goes on, and we can bring on the things which perhaps from your real rich experience and perhaps from my little bit of academic experience, we can just bring it together, and perhaps it can be a rich discussion. And it's really like touching, that kind of things which you just shared. It's amazing, Dr. Chala. Yeah, over to the speaker.
Okay.
Okay.
Good evening to everyone. I am thankful to the chairpersons, the organizers of the Thursday meeting, especially Dr. Alim, Dr. Shobit, Dr. Vishal Chhabra, Dr. Tufan Pati sir, and our chairperson, Dr. Gaurav and Dr. Kishan Vasant Venika. I will briefly go through my experience.
I think Dr.
I
Riaz.
think his connection is dropped.
Yeah, मुझे वही लग रहा था. Low band.
Okay.
Amit,
Now
can
I
you
am
inform him
connected.
that?
He's back. He's
Yeah,
back.
yes, yeah, sir.
He's
You're
back.
back, sir.
Welcome back, Dr. Riazuddin.
Okay. Can we see my slides?
Not yet.
Can I share my slides?
You can. Are you able to share the screen?
Yes, I've shared the screen. It is not visible.
No, so not visible. So you kindly unshare it and again do it.
Okay.
Stop the screen share and redo it.
Now it is visible.
No, not to me.
Shobit, do you have the slides with you?
Dr. Riaz, if you can share it with the slide with us, we can play it from here. Meanwhile, chairpersons can actually.
Okay, I'm trying on.
In between, if chairpersons want, they can. Dr. Riaz, you try again. I think it will be now. Your photo is there now.
Meanwhile, sir, we can have responses from the audience. how many of us use ketamine from the audience, sir? In the chat box if they can contribute.
Yes, the screen sharing has started. Now gone again.
I think network का issue है सर.
So there are responses which are started to come in the chat box, sir. Never used. Dr. Suhas has used. Dr. Sanjay has used. Dr. Majid has used for more than 50 patients. Ketan has used it for the last 5 years. Dr. Zeba has used. Dr. Anshu has used in bipolar depression with good response. Have referred many patients, seen very good response. Dr. Ketan is used in opioid withdrawals for severe pain. Interesting. Dr. Saha, subcutaneous use in treatment-resistant depression patients.
As phase 3 trial.
Well, interesting. I think iPhone, I don't know the name, tried in 2 patients. One patient had seizure. Someone has said excellent response. Dr. Sanjay said mixed results from oral. I think everything will be addressed by Dr. Reyes.
I have a follow-up question if we've got enough responses. What prevents one from using ketamine? Like, what are the hesitations people have in using ketamine?
Dr. Majid said we use it regularly, daily 3 ketamine
Hmm.
sessions at our centers. Tabligclinic.com. Alim sir, shall we call Riyaz sir?
So we're getting answers. Dr. Raj has written availability issues. One is not able to use. Availability is a major issue. Dr. Siddharth has also written.
Can I
So,
Yes,
sir,
Dr. Krishna.
regarding the usage of ketamine, one of the doctors have asked me, are the psychiatrists qualified enough legally are they eligible to give ketamine? So that's why there are some fear in some psychiatrists, which I have seen. So ketamine is an drug which is mentioned in the national list of essential medicine. Just like methadone and buprenorphine, ketamine, any MBBS doctor, any registered medical practitioner can give ketamine. Especially in our subanesthetic doses, it is safe, and any MBBS, any RMP can give it to their patients freely. It's a Schedule X drug, so the stock and the patients who are receiving the ketamine, the records should be maintained for at least 2 years, as it's a Schedule X drug. So its availability also is a issue in some places. Okay, this is my comment. Thank you.
So then there are also like some of the things which also are concerns by the anesthesiologists, especially who have been using, although they say that it's a whole and soul anesthetic agent because it doesn't, cause the muscle relaxation and it just does its work and it's like very, smooth anesthetic agent and it can even give in children. But the concern which they raise is, which is very minimal, but at the same time it can be very serious, is that sometimes it might cause laryngeal spasm. And because psychiatrists, they are not, unfortunately, like in India, they're not very well trained to how to intubate the patients, and also that becomes a risky situation that way. And the other thing is like if the dose is given more than what is prescribed, obviously there were some complications. One of the persons mentioned seizures and all. And then there are some things like it can also cause hemorrhagic cystitis. And you have to like a delicate balance, you have to use it because there have been also like instances when the people had bad trips and then the people even even died. Yeah, I agree to what Dr. Shafi said, but at the same time, but the risk can't be like, ignored completely. That's just my take. Yeah.
Dr. Krishna? In response to that, what do you have to say about the side effects? Do you see any of those risky, I mean, those side effects, major side effects in any patients in 10 years you've been using? Yeah. You need to unmute, Dr. Krishna. You're still on mute.
Okay. Sorry. Okay. As I already stated, we have experienced some side effects. One of the thing is nausea and vomiting. So 5 patients we got vomiting practically. We generally we tell them to have nil by mouth from the morning or a pre-anesthetic antiemetic in the cases who got already a vomiting history of vomiting somehow. So we should have some jar with as vomiting tub or sink nearby. So it's and other thing is the oral ketamine. If we give oral ketamine, it has a different taste of Ayurvedic kashaya of a very difficult taste. First time I took around along with plain water. So plain water is very difficult to taste, and the nausea will be high. So it can be mixed with a juice to prevent it, and ketamine will give increase in the pressures. So it will increase the uh, hypertension. So some sudden sympathetic surge and followed by the acute decrease in catecholamines will be there. So even it's used in cardiac surgeries as well as an anesthetic. So it's very safe. But persons who are having the premorbid things, we should be careful. So we should be cautious in coronary artery disease patients. Otherwise, it's a very safe thing. Okay.
Thank
Thank
you.
you.
Thank you,
Thank
Krishna.
you.
I think we all set now. Dr. Riaz, you can proceed. You can unmute and proceed, Dr. Riaz.
Uh, Sorry for the delay. So I will going to tell about ketamine use in daily psychiatry care. Uh, so this was the content of my presentation, like introduction, pharmacokinetics, route of administration, efficacy, and procurement. The introduction to ketamine. Ketamine was introduced as an anesthetic drug about 50 years ago, and it is now used off-label for pain management, sedation, depression treatment, particularly in sub-anesthetic doses. Traditional antidepressants shows limited efficacy differences, with remission trials in a study like having 28% in step 1 and 10% in step 4. So there is a rapid read for rapidly acting antidepressant in emergency and refractory cases. Ketamine here is a promising tool for rapid antidepressant effects, especially like a breakthrough like similar to clozapine for depression. The mechanism of action, ketamine is an NMD receptor antagonist, potentially facilitating glutaminergic activity, upregulating AMPA receptors, leading to neuroplasticity. However, the exact mechanism for antidepressant effect is unclear. NMD antagonism alone may not suffice, as other antagonists like memantine lack similar benefits. The ketamine, the approval is for IV anesthesia, ketamine for management of post-surgical pain, especially to transdermal route, and S-ketamine for suicidal ideation and treatment-resistant depression. Ketamine can be used for off-label use for pain management, for post-operative care, cancer pain, refractory headache, for control of agitation, violence, pediatric sedation in dentistry, radiology, for management of acute asthma and asthmaticus even in children, status epilepticus in children, depression, alcohol and substance dependence with psychotherapy, is valuable maybe in GAD, SAD, OCD, or PTSD, and for every action. The pharmacokinetics, that oral viability is 20 to 25% due to high fast first pass metabolism. It is higher with sublingual route. However, parental intranasal route offer complete bioavailability. It is rapidly distributed. Plasma life with IM and subcutaneous route is half of that IV. Primarily, it is metabolized by CYP2B6 and CYP3A4 enzyme, converted to active ketamine. Enzyme inducer reduces plasma level and inhibitors can increase it. It is mainly excreted via urine. The elimination after IV usage, the half-life is 2 to 3 hours. Benzodiazepine may diminish its effect. Glutamatergic inhibitors like lamotrigine reduce its adverse effect, but impact on efficacy is unclear. The route of administration is variable. This is a chart which showing the comparison of the different routes. IV is commonly used. It is 100% bioavailability. The typical dose range from 0.5 to 0.75 milligram per kg body weight over 40 minutes in 500 ml NS or 100 ml NS. It is best suited, most reliable levels, but it needs setup and it is ritualistic. IM and subcutaneous can be given in the bolus. The bioavailability is half of that IV. Is simpler than IV, but still injection is needed. Intranasal comes in fixed doses, 56 to 84 milligram, approved for by FDA, but it is costly. Oral route has poor bioavailability, that's why it requires higher dosage. The dosage ranges from 1 to 3 milligram per kg body weight. 1 ml contains 50 milligrams, so that's approximately 150 to 300 milligram. It is easiest, cheapest, and domiciliary possible. So the oral route, the oral ketamine is maybe easiest and empowers all clinicians, especially for emergency use, repeated dosing. For acute phase, a single session for acute need or can be given thrice weekly for 2 weeks. Maintenance is individualized for patient to patient, and we have to continue the oral antidepressant. The oral method can be given 175 to 200 milligram in 100 ml of water or juice, and it has to be sipped over 12 to 15 minutes. The more the time, the dissociation the chances are very lower. Repeated domiciliary dosing at night with oral ketamine has been described up to 300 milligram per occasion for up to 2 years by a study by Al-Shirawi et al. Antidepressant, including sedation, can be minimized by slowing the speed of sipping ketamine. The adverse effect can be attenuated across repeated sessions. Intranasal ketamine is approved by FDA for TRD. It comes in a fixed dosing, 56 or 84 milligram. In the first 4 weeks, it has to be given twice weekly. In the next 4 weeks, it has to be given once weekly. Now onwards, it could be given once or twice. It requires monitoring. 2-hour monitoring is mandated. The practical consideration that procurement of ketamine. Number 2, that the patient should be fit for ketamine. It is a procedure, that's why we have to take consent. We have to clearly explain to the patient the effects going to happen during the sessions or after that. There were need for a side room, bed, and a wash basin. It can be consumed in empty stomach to reduce the vomiting chances, or can be given with ondansetron to reduce the nausea 1 hour before the ketamine infusion. There should be a need for caregiver. Monitoring is needed, and we have to be prepared if any dissociation or dissemination occurs. And most important, documentation is needed. Ketamine is a very safe drug, much safer than other anesthetics. Does not depress cardiovascular or respiratory responses. Has been safely administered by nurses with no experience in sedation in emergency care. Various studies have reported it. Ketamine is no more a heroic or risky than ECT, clozapine, or large number of drugs in the pharmacopoeia. This is quoted by Dr. Chittaranjan Andade, sir. The antidepressant effect is very effective. It is reported by multiple RCTs and meta-analysis by Kishimo et al., which included 234 participants. There were 9 RCTs included, which shows a higher response with ketamine than control. And the antidepressant effect is evident at 40 minutes, peaked at day 1, but it is lost in 10 to 12 days. Almost all data are from the unipolar depression, but few studies include the bipolar depression also. A study by Zarate et al. Conducted in TRD, the small number of participants was there, 90. The response rate was 71% in day one, and this means the remission was 29% on day one. Response attenuated, but still evident at week one. Most important to note that not every patient of TRD responds or remits with ketamine. Serial dosing or maintenance may be given with augmentation with other treatments. Efficacy in suicidal ideation, it is reduces suicidal ideation within 1 hour and lasting up to 1 week. Effect is partly independent of the antidepressant action. A meta-analysis by Wilkinson et al. shows a large effect size of 0.92, which include 167 participants. At 1 hour, there was achieve a remission rate of 55%, and there was reduction of 50% in suicidal ideation. The NNT was 4. Oral ketamine similarly shows a good response rate, like 30 to 85%, remission 25 to 45%, and reduced hospitalization in TRD patients. And it is well tolerated. Context of ketamine use, the valuable scenarios could be, it can be used in severe and refractory illnesses, acute suicidal risks when admission is not possible, social need for rapid response, bridge to MAO inhibitors, alternative to ECT in selected patients, helps until other interventions are instituted and take effect. These are the most valuable scenarios can be used. There was no head-to-head trial between ketamine versus RCT, but a small meta-analysis was done by Dr. Vikas Menon et al., which includes 5 RCTs, and it found that ECT is superior in the final depression score. The SMD was found to be minus 0.39. The study response having a relative risk of 1.27 in 3 RCTs, and remission rate, the having relative risk of 1.43 in 2 RCTs. There was more important to note that no significant differences for sessions to response and remission was seen in this study. Similarly, other studies by Ikran et al. And Sharma et al. Showed a better efficacy with ECT than ketamine. But ketamine offers advantages. It is faster onset of action and offers no minimal or cognitive side effects. This is a trial recently published in JAMA Psychiatry, which shows that serial ketamine infusion as an adjunctive therapy to inpatient care for depression. Here, the effect was not seen, that the group differences has been minimized at the end of 6 weeks or 12 weeks or 24 weeks. This is a surprising result, as most of the other studies previously done have shown a marked efficacy. But this is a milestone study, so we need more research. The most probable reason for this that the patients that were admitted were offered greater care, and itself it has a therapeutic benefit. And second, most of the patients are moderate to severe depression. The adverse effects are transient and manageable. Is it dose dependent? It resolves within 4 to 24 hours. This is unlikely to have a dissociative effect. Neurological symptoms like unsteadiness, diplopia. There may be a transient raise in heart rate or blood pressure. Nausea is very common, and which can be prevented by giving ondansetron. In long term, especially in drug abusers, we found uropathy or LUTS, which can be minimized by proper hydration and monthly urinary checkup. No neurotoxicity at therapeutic doses was reported. It is very safe in comparison to ECT and clozapine. This is a review article which shows that patients who uses ketamine for a short term have no neurological symptoms in psychiatric disorders. So in this systemic review, usage of ketamine in psychiatric disorder was not associated with any significant neurological symptoms. This is a recently news that long-term ketamine uses causes neurotoxic effect in preclinical human studies. So this cautionary study, we have to need do more studies and to benefit what was the beneficial result in the long run. So this review shows that ketamine shows neurotoxic deals with high dose or frequent use, while clinically used S-ketamine appear cognitively safe. Long-term comparative longitudinal studies are further needed. Setting up a ketamine clinic in India. Legal requirement that ketamine is not approved in India. Used off-label for depression. Psychiatrist-led administration possible without anesthetic for sub-anesthetic doses. It is governed under NDPS Act and Cosmetic Drugs Act. It is required separate licensing for handling by the pharmacist. Clinical setups, need for medical license, compliance with the storage, record keeping, and prescription rules. There was a more important thing to note that there are no mandatory requirement for anesthetic supervision in psychiatric use. Guideline emphasizes safe administration in clinical settings. Procuring ketamine in India. Can be directly procured from the manufacturers by the hospital pharmacy or medical specialist having a valid registration number. Important to note that those medical specialists are using in some anesthetic doses don't require Schedule S licenses. It is very cost effective. It requires only 120 rupees per vial. Regulations, especially we have to document the use of ketamine for at least 2 years, and violation can lead to penalties. This is a chart showing the uses of ketamine in daily usage, which can be easily sipped in a glass of water by mixing 0.5 milligram or 1 milligram or 3 milligram per kg orally and given to the patient. Most of the studies, there was no definite guideline for oral racemic ketamine. Dr. Andrade was pioneer in coining this procedure in India. So he has published different guidelines, and anybody who are interested can go through his guidelines. This was published in Indian Journal of Psychological Pharmacology. I'm not going into the details. So anyone who are interested can go in detail. So final conclusion is that oral racemic ketamine is reasonable, effective, well tolerated, affordable option for rapid relief in TRD, suicidality, especially suitable for resource limiting settings like India. The strongest evidence for IV, growing support for oral, recent Indian studies and global RCTs shows response rate up to 85% and good tolerability. Is still off-label, experimental in many guidelines. Need more long-term safety data and optimization of dosing, promising ongoing research, repeated oral ketamine in TRD or adjunct in OCD. This was my publication. We have done a randomized study in which I compared the oral ketamine in suicidal ideation in depressive patient in comparison to midazolam. We found that oral racemic ketamine is reasonably well tolerated, rapidly effective intervention, suicidal ideation, and depression in adults with major depressive disorder. This is a case report of use of intramuscular ketamine for treatment of depression and suicidal ideation in 6-year-old child with congenital tracheoesophageal fistula. This is a study we have done, but it's not published, that compares the efficacy of intravenous versus intramuscular rate of ketamine in major depressive disorder. We found that both are equally effective in treating suicidal ideation in depression. There are some study we are doing like efficacy and safety of repeated oral ketamine in treatment-resistant depression, feasibility and efficacy of oral ketamine as an adjunctive domiciliary treatment for obsessive compulsive disorder. This is a vial we used to procure from Troika Pharmaceuticals by the hospital pharmacy, and we can also purchase from the department side. This is a vial. This is the administration room, which requires a bed, minimal monitoring monitors like BP machine or SpO2 monitor on a wash basin. This is a video I'm going to show. I'm requesting organizer kindly stop the recordings. Patient was offered oral ketamine. The patient was given oral ketamine, and
Yeah, thank you. Thank you so much, Dr. Riaz. I think it was really very practical, very to the point, and those who want to start that clinic, they will have a good overview right now. So you can stop the screen share, Dr. Riaz. And
Yes.
thank you so much. And any opening comments from the chairpersons? And we invite questions in the chat box.
So I'm very thankful to the speaker for the comprehensive presentation, lucid and up to the mark. He covered every aspect, including the forensic legal aspect, how to procure and how to use it, including the side effects and its management, and the case as well. Case. Uh, in continuation with my previous statements about the use of patients in cardiac issues with the presence of cardiac coronary artery disease or any cardiomyopathy. So from that one instance we got of cardiac arrest in a diabetic hypertensive coronary artery disease patient who is of 60 years age. So from then who has a history of cardiac illness, we are giving in attached ICU setup in a hospital. Otherwise, in a psychiatric clinic only, we can give. And regarding to dizziness and the swaying, so my from my personal experience for during my ketamine session, so we usually ask the patients to empty their bladder before giving the ketamine because after giving the ketamine, persons will become sedated and dizzy. So to get to the washroom, I stood up and went to the washroom, and I got the swaying and the dizziness and diplopia of seeing my mother as too, and do on the switch of the washroom light. It took me 2 minutes. So I'm it's like past pointing in cerebellar degeneration of alcohol patient. I'm around the switch and I couldn't get to the switch. So finally I got the switch, but due to fear of any fall in the washroom, I came back and slept on the bed. So ketamine gives some sedation and post therapy until the sedation was completed. It's not safe to stand or walk. And coming to dissociative symptoms, I experienced depersonalization for the first time in my life. So my both hands appear to be like trunks of an elephant, and myself witnessing them. And after that, I felt like my soul is coming out of my body and floating around 4 feet above my body level in the bed. So these are the due to dissociative symptoms and is due to dizziness and swaying. So we have to keep the patient for 1 to 2 hours to sleep as much as needed on the bed itself until they are confident enough to stand and walk. So this is my practical experience. So we usually ask the patient to empty their bladder before giving the ketamine. So this is excellent and lucid presentation. There are quite good questions from the audience and common questions.
Dr.
Dr.
Krishna,
So
I have a question for you because you
okay.
shared your lovely experience. Just want to understand what you told us about diplopia, not able to switch on the button and feeling disoriented, depersonalization. Did it happen on each, or only on the first time, or subsequent also it is happening on
So
each?
it was happened in the first session and second session. And third and fourth, I never experienced it.
Anything.
So and coming to disorientation, there's no disorientation during any of my sessions. Clearly, I heard what are the clinician is speaking, my mother is speaking. I can speak myself with coordination, with thinking actively.
So
So
you knew where you were, what time it
yes,
is. That
yes,
was
for
all clear.
everything I am oriented.
Okay. Oriented time, place, person.
Exactly.
Correct.
Dr. Diaz, I think a very, very good presentation. Few questions from the chat box, and we will serially take it up, Dr. Diaz. When you start,
Mhm.
like when we should start ketamine, one antidepressant failure, two antidepressant failures, subsequent failures to the treatment brings treatment resistance more into account. So when we should start ketamine, specifically, it is not an approved treatment.
Especially it is used in off-label treatment, especially in emergency cases. We have to individualize from person to person. If patient has suicidal ideation and patient needs active treatment, that drug is going to take time, so we have to give it. So this is the first procedure. Number two, that if for TRD, the standard definition for TRD, after TRD, patient can be offered ketamine treatment. And
Okay.
it could be personalized from patient to patient also. Sometimes
Okay.
a patient with severe depression requires a rapid treatment improvement. We can offer him a sub-anesthetic doses of ketamine, especially if it's off level, of course, it is not recommended by the guidelines.
Can you tell us a dose, sub-anesthetic, how much is the average
Point
dose?
0.5 milligram to 1 milligram per kg body weight.
So do we have an anesthetist team member along with us?
No, there was no requirement of any anesthetic team for.
Any minimal mandatory investigations to go about before starting ketamine?
For sub-anesthetic dosage, I don't think there was any investigation is required, especially when you're offering it OPD basis.
Like
But we should avoid from elderly patients.
okay, okay. And any specific precautions in special populations like children, pregnant ladies, and elderly population?
We don't offer OPD-based treatment for elderly or children. It should be admitted for proper monitoring.
Okay, okay. And there are a lot of questions that is what is the benefit of using ketamine with ECT, either as an
Yes,
in TRD, and one question about in mania also.
there was a lot. Basically, we are using ketamine in our centers for three purposes. Number one, for sedation for acute management of violence. Number two, with 2 ml ketamine plus 2 ml ketamine plus 2 ml midazolam for IM muscular route. And we found it very effective rather than haloperidol and phenarpan. Number two, situation for suicidal ideation. Number three, we use ketamine in ECTs. We don't use propofol. And there were several studies which reported that there was very not a significant reportion that patient who are used ECT with ketamine has a rapid improvement or more improvement than propofol. However, other studies are required for this.
Okay, and we generally would discontinue benzodiazepines before ECTs. Any medication to be discontinued before giving ketamine in context of
No,
any?
no, there was no reason to discontinue any medications.
Okay,
Ketamine offered an advantage. If an anesthetist was not there, we can give the psychiatrist or junior resident can give ketamine and give ACT. And that was a partially modified ACT.
and you said sub-anesthetic dose of IV ketamine thrice a week for 2 weeks.
Yes.
What is the schedule for oral ketamine and how much we can give it?
Oral ketamine, the same dosage, or alternate days, for thrice weekly for 2 weeks.
2 weeks and
The problem is that domiciliary treatment, domiciliary, the logistic is very important concern in our centers or any other centers. Patient don't want to take it on alternative days, come to our OPD and take it collected. So we usually offered him 3 vials in a week, but even they will discontinue it.
okay, okay. And we generally say that because it's a euphoric agent, short-lasting effects, generally, that is a consensus.
Yes,
So we titrate antidepressants from the background?
yes.
Uh,
If patient don't get response in the first session, we can up titrate it. 0.5 to 0.75, 0.75 to 1 milligram.
as an augmentation.
If
So if
patient don't get saturated.
but if patient is on oral antidepressant, shall we also keep on
Mhm.
taking it, or we have to keep those doses same as per one of the questions? Dose of antidepressant after ketamine.
Dose of and antidepressant should be no, antidepressant should remain there. The dose should remain there. If patient don't get improved after 2 to 3 sessions, then we escalate it.
Okay, okay. And as you said that we need Schedule X license in pharmacy. So as in single chamber practitioner, I don't have a pharmacy. How I should procure it for OPD practice?
For medical practitioners having a medical license, we don't need any X license. It's only for stockists. If any stockist was there, they have to procure a X license. Or for a medical professional, we don't need an X license.
Okay. And supposedly something happens to the patient because it's an off-label treatment. I know most of the psychotropics we use in psychiatry is actually off-label. Then what thing will save us from in court of law?
That was only the consent, and explicitly you have to explain it to the patient.
So any specific formats for the consent, Dr. Riaz?
There's no specific format because patients are mainly more concerned about two things, that dissociation and unsteadiness. When we counsel it properly, we frequent sessions, with subsequent sessions, the dissociation goes away, and hardly a very less number of patients dissociated.
Okay. And in pregnancy, in special population, in pregnancy?
I have never used in pregnancy.
Okay. Dr. Alim sir.
I think how long to continue then? Once you start ketamine, you get response. Then
Basically,
after that, how
we
long?
are in our center we are using for 2 weeks, but there were other studies which has given for 1 year also. Dr. Chitanjan had told me that some people have used for 2 years.
So suppose after 2 weeks the patient has improved, and how about suppose you stop and then they relapse again? So what is this data? What is this angle?
Basically, it is I assume that it is just a first aid till the other treatment modality works out.
Basically, you have to
And
keep on building the antidepressants in a upper dose
yes, sir.
till the time the antidepressant take effect. This is
Mm,
a rescue medication for that.
yes, yes.
Okay, got it. I think Shobit, you have covered all the questions in one go from the chat box.
Yes.
Yeah,
Yes.
are there anything left?
Sir, maintenance ketamine. I know, Dr. Reyes, it's a difficult one.
Maintenance ketamine, Dr. Chitanjan has using ketamine in maintenance therapy also, and he used for 12 weeks, 24 weeks. But again, for my center, or I am using, the most important concern is the logistics. Patients don't turn up to take ketamine in a regular basis.
Okay. And an OCD.
Shobit, Dr. Majid wants to share his views. He has given to a lot of patients.
Yes, sir. Yes, sir.
Dr. Majid, if you can unmute and share your experience briefly.
Yeah, am I unmuted now?
Yes,
Yes, you are there. Where are you practicing, sir?
Yeah, I'm in government practice as well as in private practice, and I use ketamine in both places, in my hospital as well as in the private clinic. Till now, I have around 450 patients and more than around, I think, 2,500 sessions of ketamine till now in my patients. And again, like Dr. Riaz said, it is mostly we use in treatment-resistant OCD or in case of where we have an urgency to treat suicidal ideations. And I have not found it. I have found it to be effective in comorbid depression in case of OCD, but primarily it is not effective for OCD even with the 12 or 14 sessions. And how we use it, we mostly use it going by the protocol. What is their what they employ for the esketamine in US? We do twice every week for 4 weeks, then once per week for 4 weeks, then every fortnightly for further 1 month. And in some case, I have 3 or 4 patients whom I have to maintain for they are maintaining only on ketamine since now more than 1 year. This is an experience of long-term maintenance, and one of them is without any oral antidepressants. But the experience with this patient was that whenever we tried to stop monthly ketamine, he relapsed back into the depression. And regarding this mania, I have one experience of using in mania. It didn't exacerbate the mania. It reduced the aggression, but it didn't help the primary symptoms of mania in that. But we do use frequently in mixed depression, mixed episode patients, where it helps to delineate, and it actually reduces the dysphoria associated with the mixed episode in case of bipolar disorder. And again, we have many patients with bipolar depression. It is as effective as in unipolar depression to our experience. And overall effectiveness is around, I think, 60 to 70% patients do respond to ketamine. And for us, we usually now in our practice is that we don't take patients to ECT unless we have tried ketamine. And somebody has asked about this using ketamine for ECT patients. We have done this in 3 patients, and it didn't help us, but it only prolonged the procedure, because coming out of the coming out of propofol is easier after in case of ECT and while using ketamine, because the doses are definitely higher than what we use for depression in our OPD practices. So there it doesn't offer any added advantage. And one frequent thing with us is that we do monitor every patient. Uh, we, Patient has to come empty stomach and all other things, and basic investigations we do. CBC we are doing, routine urine examination we are doing in every patient. Hello.
Yes, yes. You're audible.
Yes, sir, you are audible. We can hear you.
I think, sir, we've lost the connection.
It is
I
there.
want to add one thing, that most people are concerned about that diversion part. That can be minimized by giving a vial of 5 ml NS combined with normal saline, combined with the ketamine. So it will reduce the diversion rate.
Dr. Diaz, one thing is that like it's your experience in OCD.
Yes, sir, I'm using UCD, but we're not effective.
Okay, and
Even if TRD patient, all patients are not responding to it.
because we talk about a lot of subtypes of depression. Any particular subtype of depression you have found it to be effective?
As such, I have not noted any particular feature.
So we just say bordering question is anxious depression or in anxiety disorders. Do we, because
Mhm.
it's a euphoric agent, does it bring some kind of an kick or high? And then subsequently, have you seen patient becoming dependent on ketamine use? Because many psychotropics we find the same.
Possibility is very high that it is also anti-anxiolytic agent. That's why the head-to-head trial between midazolam control studies are important to delineate the effect.
Okay, okay, okay. And in panic attacks?
And I am not using panic attack. I am using some patient of convergent disorder.
Okay,
So some patients
I think
responded dramatically after, especially it is not a good scenario that we sometimes a patient with convergent disorder repeatedly coming to emergency. If we use a higher dosage, dissociate the patient, maybe that it is act as a deterrent. Patient will not come again.
and we have seen almost all the agents given for to combat depression. Even ECT can cause switch. So
Mm.
ketamine can cause
No, there
switch.
was no. I have not seen any kind of switch in any patient. If it is there for for few hours only.
Okay, okay. Because all the questions in the chat was very relevant because most of the disorders are also comorbid with depression, like PTSD, borderline personality. So in these contexts, what is your experience in comorbidities? Does it only isolated affects depression or it also helps in other comorbidities?
I cannot comment on this. I have not have experience on vast experience on.
Right. I think questions are pouring in, sir.
Yeah, yeah. Regarding this urinary tract issues,
In rare
so
cases, it is reported in drug abuser who are ketamine users, especially in Western countries. We don't see here in Indian settings. And in subanesthetic doses, I don't think any patient has reported ever the patient has urinary complaint.
okay. Dr. Gaurav, would you like to share your experiences?
Yes, sir. Some of the things. Thank you so much, sir. And it was a lucid presentation and amazing experience by Chalakrishna Vasan sir, and amazing questions by Shobit sir and Majid sir. Everything. There's some of the things like there's some of the questions actually which some people asked. One of the things was like giving anesthesia with ketamine with the ECT. So the thing is like it was something which was proposed in the Canadian guidelines, and perhaps like if people go through that, they will understand this. The problem with that was like although it has become a part of Canadian guidelines, but the problem with that is the seizures are prolonged, and the other complication is that you are going to have some prolonged cognitive deficits, which are not seen with the ketamine therapy alone. So that are their studies. Again, like in India, the thing is that we have to do some detailed studies on that, but that's what they said. And then there was other thing also like regarding like some people they report of confusion following ketamine. So what even practical experiences and what even like somehow the studies what they mention is like ketamine can cause something which is called as emergent delirium. So what happens is that to overcome that emergent delirium, people use midazolam with ketamine, and it has to be given like over a period of 45 minutes. So the effects of ketamine, while they are like going off and the emergent delirium appears, the midazolam kicks in. All right. And then there was also one of the person who asked like what happens like in the ketamine sessions, can you even do the therapy? Like in the beginning, before midazolam kicks in, people can do the psychedelic assisted therapy with ketamine. So what they do is like obviously it starts with a ritual, and then there's something which is a specialized kind of breath work, which is much more complicated as compared to JPMR, which people have mentioned, and that's called as holotropic breath work. So what happens is that you listen to like there's a surrounding around you, and at the same time there's a suggestion which works with you. But it all works with the perhaps people will disagree with me when I say this all things, but they start with free association and then they start with the psychodynamic psychotherapy after that. Like some of the things which are from the Hume, and actually they are actually working towards something which is called as individuation, where they start working with the shadow work, like your the evils and your persona, they all come together, and so you start understanding it, and this complete the therapy, when you start doing it, even like you have to understand the dream analysis, like the condensation, displacement, and symbolization, all those things you have to do this. So these are just a part of the therapy, and this is not science exactly. And then there was some other thing which was just mentioned, like for instance, like is it just the ketamine levels which just keep on building up, and when do we stop it, when do we start it, and when do we stop it? So, like people like there are studies which have mentioned that initially it can cause this is NMDA antagonism, which is just considered as a gateway pathway for depression. And then this it's also like having a small amount of sigma activity, which starts acting on antidepressants, having an antidepressant effect. And then it also has a little bit of opioid activity. So that helps in the pain component. Like what happens is in the pain, like what happens is like there's a pain. What happens? It starts with a pain, and then there's a downward spiral. Like the pain, like it keeps on getting worse because of the cognitive component of the pain. So it just like compresses that square spiral, and you don't have pain at all. That's what people are saying towards while doing the ketamine therapy. So in that case, it does help, and in the depressive patients, it do work. It does work. That's what people say with their experiences. And even like the people, it's not like you just take ketamine therapy and you get high and it just goes away. Like there are other psychedelics. The thing is like it permanently changes you. Like after the NMDA, it also starts on this thing. There are other pathways also. Like one of the things is one of the mTOR receptors actually, which are in the frontal cortex, prefrontal cortex and all. So the connectivity keeps on improving after you keep on giving the ketamine sessions. So the amount of sessions you keep on giving, your prefrontal cortex also start getting developed so that it becomes so much mature that perhaps your the punitive prefrontal cortex, it stops acting, and and the other parts of the brain, they start functioning, and perhaps your depressive symptoms, they go away. And regarding the trauma is the thing is like it's a very complex concept, because like trauma doesn't get only stored in the brain, it gets stored in the brainstem. And it also like, it gets activated when you do the EMDR, when you keep on moving the eyes. Please stop me if I'm speaking a lot, sir. So even like if you keep on moving the eyes, and then this trauma just suddenly gets in front of you, and then you help in processing that trauma through that EMDR kind of therapy. So people have experimented with under the EMDR, under the influence of ketamine, and that has worked with people, and they're having the long-term benefits. And regarding the OCD, if there's a lot of cognitive part of the OCD because of which the person is depressed, it can help. But regarding obsessions, the receptors don't make sense actually, like why I should do. And regarding the schedules of ketamine, Maudsley has clearly mentioned, this 15th edition has clearly mentioned like the 2 years, it has given that thing that you can give it once in 15 days. So it has mentioned it clearly. Like you can give it once in 15 days, once in 15 days, like that, it has mentioned it. So that it can have the lasting benefits. So these were some of the things which just came into across, and that Sir's study on Wilkinson et al. It's like I'm a fan of that study, which Sir mentioned in his presentation. It's done an amazing job. Like he says that how it just prevents the suicidal ideation. The thing is like in the suicide one, the person like we don't see suicide that way, but the people from the West, they see suicide in some other way. It's a time when you have clouding of your consciousness. You don't know whether you have to live or not. So basically, you lose your capacity at that time. So it's almost parallel to psychosis. So that thing, ketamine, brings you back and it helps you reviving. So that's the thing, some of the things which I've just mentioned, some of the things which I've seen from my experiences and some of the things I've seen from the others' experiences, but still a lot has to be developed in this field, sir. Sorry, I've spoken a lot, sir. Yeah.
Oh, thank you, thank you. You're most welcome, sir. You're most welcome. So, Shobit, have you covered all the questions?
Yes, sir, mostly. Sir, one last question from my side. Dr. Reyes, with so much of evidence pouring in, and then maintenance, and then sustainability, why it has not been approved till date? I'm not talking about esketamine.
Again, is it because like other drugs, psychotropic has been clubbed into NDPS Act? That one of the major block, I think, for approval.
No, but correct me if I'm wrong, but for approval, somebody has to put an application, first of all. Who's put an application for that? You tell me. So unless there is a money to be made by a pharma company or an association like Indian Psychiatric Society who puts an application, government will not approve because government doesn't know. That is very important to understand.
Oral ketamine, racemic ketamine is very cheaper. That's why pharmaceutical company will not pursue it.
No, but I think as an IPS or maybe somebody has to put an application for the approval of this. Then only this will be approved.
Yes.
I think we have covered all the things. Yeah.
Yes, sir.
Yes. So today we had a very practical session. And any closing comments on the chairpersons? Then we go to the thanks. Krishna, any comments from your side? Any thing to share to us?
So, ketamine is actually very safe. It was given from young 1 year infant till 80 years of old age. So it's very safe in subanesthetic doses. So the one of the questions that came in chat was regarding death with the ketamine. With our subanesthetic doses, there are only some cardiac issues which are temporary and patient will be revived back. So no much issues with it. It's very safe and very good drug. So thank all the persons who contributed and who shared their points with along with the speaker. Thank you. Good night.
Thank you. Thank you. Gaurav, anything from your side?
No, sir, it was an excellent presentation. This is the beginning of like ketamine and like sir's like work is excellent, but at the same time we also need some legal backing while we do this so that we are not into any kind of trouble while we do that. It's a wonderful thing because like it will open doors for psychiatrists, not just for the patients when they're thinking. It's going to open doors and opportunities for the psychiatrists, especially the young ones. And also like it's something which is like substantial, which will actually show to the patient that yes, you are improving. Okay, so that's the thing which we need. We need some legal backing on this, sir. And thank you, Dr. Mohammed, and thank you,
Yes, sir.
thank you, Shobit, sir. Thank you, Dr. Tofan, Dr. Vishal Chabra, sir. Thank you so much for giving chance to come over here.
Thank you. Thank you. Tufan sir, over to you.
Amrit is there? No. Amrit is here?
No, sir.
I don't think so, sir. You have to
आप ही
wind up
कर
the
दीजिएगा।
session also.
Okay. It was an excellent presentation. Ketamine, all of us knew, but honestly, I have never given ketamine. I am in there more than 40 years. I have never given ketamine. And then adjunct in UCT, I don't find anything. Why should we prefer ketamine? Does it improve the antidepressant effect if combined with UCT? But ketamine appears to be a very good medicine. We can try it. Basic thing, it is not legal in India, that hinders. The places where I practice, they don't want it. No hassle. But thank you, Dr. Riyajuddin, for excellent presentation and rich inputs by Dr. Krishna and Dr. Gaurav Uppal. Thank you. Thank you very much.
Thank you.
And
You're welcome, sir.
I thank all the moderators and I thank all the audience. all the people who joined this, around 200, I think, Dr. Vishal.
Yes, sir.
So,
Yes, sir.
thank you, everybody. Thank you, Talent Pharma, and have a good night.
Really, thank
Thank
you.
you.
Thank you, everyone.
Thank you, Krishna Gaurav. Thank you, Dr. Riaz.
Thanks,
Thank
Dr.
you.
Riaz, Dr.
Thank you.
Krishna.
Ending the meeting now. Ending the meeting.